بفطرتنا للقيم برانا بارينا، كنا رجلا صرنا أمما نرقى برقي مبادينا.
In the next lecture we cover the alimentary canal structures, stomach, small intestine, large intestine, and today we will cover what's there in the abdominal cavity, the accessory digestive organs. Those will be the liver, pancreas, and gallbladder. In addition, there is a unique organ in the abdominal cavity. We will speak a little bit about it because of its relation to the peritoneum, which is the spleen. Okay? Which is part of lymphatic system, lymphoid. It's a lymphoid. Okay, start with the most important one, which is the liver. When we speak about the liver, you have to know it's the largest organ with the exception of the skin, of course. So if you're going to consider the skin, it will be the second largest organ in your body, but it is still the largest gland in the human body. You know, the liver is a very important organ because it carries numerous functions. Its first, most important, is filtration of the blood before returning it back from the intestine to the heart. So it filters the blood from foreign organisms and structures. Second function is bile production, okay? To produce bile, which is important for the emulsification of fat during digestion and absorption process. So it's related to fat digestion and absorption. And lastly, it carries out different metabolic activities related to proteins, fats, and carbohydrates. Okay? And this must be covered in the biochemistry part, the biochemical part of this system. Speaking about the structure of the liver, if you look carefully, you see that the liver has two main surfaces. A superior anterior surface, as you see here, which is convex, okay, more or less, because of the concavity here of the diaphragm, okay, which is facing the diaphragm superiorly and anteriorly the anterior abdominal wall. So this will be named as the anterior and superior convex surface. We will name it as the diaphragmatic surface because it is reflecting underneath of the diaphragm. Okay. The second surface of the liver is located inferior posterior, and this is flat or more or less irregular in shape. Because it is flat, it must be flat, but it is becoming irregular. When I say irregular, there are depressions on it and elevations. These depressions, we call them impressions of heart, happen because of organs in close contact with the liver there, like the stomach, the right colic flexure, the right kidney. So these structures which related to the liver anteriorly, as you see the stomach here, as it's in close relation to the liver, it will form an impression here, gastric impression. So on this surface, so many viscera, organs, producing impressions on this surface. So I would name this surface because of its relation to the viscera as visceral surface of the liver. Okay? So the visceral surface of the liver is the inferior posterior aspect of the liver, okay, and it is in close contact or in proximity to several organs within the abdominal cavity. We will start talking about the diaphragmatic surface first. When we speak about the diaphragmatic surface, there are three things to cover. We have to know what are the subphrenic spaces, okay, what is the falciform ligament, and what is the pair area of the liver. These three terms relate to the diaphragmatic surface of the liver, to the superior anterior surface of the liver. We speak about the subphrenic spaces first, okay? So we speak about the subphrenic spaces. Look carefully with me. If you remember that we said that the liver is an intraperitoneal structure, okay? And this intraperitoneal, it must be covered by peritoneum all around, okay? So if this was, for example, the liver, and we have this peritoneal sac coming towards the liver, okay? You have to know first that the peritoneum reaches the liver from below during the meal. The peritoneum starts from below up. So the liver is the most superior structure in the abdominal cavity. It's just beneath the diaphragm. So as the peritoneum reaches the liver from below, it will go and cover all the way around the liver. Okay? As doing this, you know that the liver is a wide organ. Okay? So as the peritoneum covering, there will be part of peritoneum going anterior to the right. It will be doing like these reflections. Anterior right space of peritoneum cavity. This we call it peritoneal recesses, pockets. So the peritoneum covering around the liver in 4 pockets or 4 recesses. Anterior right recess or pocket of peritoneum, anterior to the left one, posterior to what? To the right, and posterior to the left. So if you look and remove the peritoneum without the liver, you will see that the peritoneal sac is forming more or less 4 recesses. Okay? 1, 2, 3, and 4. Okay? These 4 recesses of peritoneum, which wedged anteriorly between the liver and the diaphragm. Okay? The 2 anterior ones will be between the liver and the diaphragm. The 2 posterior ones, superiorly they will be between the liver and the diaphragm, but inferiorly they will be between the liver and another organ located there. In the right side, for example, there is the kidney, right kidney. In the left side here, the stomach. Okay? So these 4 recesses of peritoneal sac surrounding around the liver, okay, we will name them the subphrenic spaces. So these are the subphrenic spaces. If you look carefully here, we took mid-sagittal section, one from the right side, one from the left side. On the right side, this yellow is the peritoneal cavity, and this is the peritoneal reflection. You can see the right kidney on the right side, and this is the peritoneum going between the kidney and the liver, and even it extends here, between the liver and the diaphragm. So this will be the right posterior, related to the liver, subphrenic space. Another one on the right side, but this time it will be between the liver and the diaphragm, the diaphragmatic surface. This will be the right anterior subphrenic space. Anterior related to the liver, posterior related to the liver. This one here, inferiorly, is separating the liver from the right kidney. So we give it the posterior right subphrenic space another name. We will call it the hepatorenal recess. So when we say hepatorenal recess, we mean the right posterior subphrenic space, or the peritoneal cavity extension between the liver and the right kidney and diaphragm from the other side. Okay? So right kidney and diaphragm behind, anteriorly will be the liver. This is the right posterior subphrenic space, or we call it hepatorenal recess. The anterior one is just separating the liver from the diaphragm and the anterior abdominal. So there is no organ. So we don't give it a specific name. It's still right anterior subphrenic space. Okay? So if you remember this view, okay? So if I look to them, in the right here we have right anterior subphrenic space. This is right posterior subphrenic space. Because of the kidney here, we will name it hepatorenal recess. Okay? Now on the left side, the anterior one here, separating the liver from the diaphragm again. So we will name it left anterior. Okay? So if you go to the left side now, this space here, as you see, between the diaphragm and the liver. Okay, this is the liver, here is the diaphragm. It will be the left anterior subphrenic space. The posterior one now, which is left posterior subphrenic space, is actually, if you look to it, it's an extension of this part of peritoneum behind the stomach, which we named it previously visceral sac. So this is a superior extension, or we name it the superior recess. This is the superior recess of the visceral sac. So the posterior left subphrenic space, posterior left, this is the diaphragm again, anterior here, the anterior left. So this one here, which separates the liver behind from the stomach, okay? It extends back like this so that the stomach is here. So it will name it the superior recess of the visceral sac. Posterior left is the superior recess of the visceral sac. 3 subphrenic spaces. What's unique in these spaces? The unique thing about them, especially this one, the posterior one, okay, on the right side, the hepatorenal recess, okay. This one here is very important when you have an ascites or accumulation of exudates, okay, due to inflammation of peritoneum. So when there is an inflammation of peritoneum, so subphrenic spaces are potential spaces. What we mean by potential spaces? So they normally, the 2 peritoneal layers, okay, these 2 peritoneal layers, if you look to the parietal one and the visceral one, or those 2, okay, parietal, visceral, they are usually in close proximity to each other. This space or this recess is nothing more than 1 to 2 millimeters only. So it's very, very narrow, okay. So the 2 layers are in close proximity to each other. So they are potential spaces. However, when you have inflammation of peritoneum, peritonitis, and abnormal fluid, ascitic fluid we call it, accumulates. Okay, so the ascitic fluid, the inflammatory exudate, okay, in pathology they name it, this ascites starts to accumulate, it will go into these potential spaces and expand. Now the most important of them is the posterior right one, the hepatorenal recess. Why? Because if you put the patient in supine position, it will be the deepest recess, as you see here, okay? So the ascites can easily accumulate in this recess, in the hepatorenal recess, in this subphrenic space, okay? Why this is important now? There will be, if there is a peritonitis, there will be abnormal accumulation of ascites in these recesses if the patient in supine position. We don't want this to happen because in normal situation, do you remember I told you peritoneum formed from below up towards the liver. The same way the flow of peritoneal fluid. So as the peritoneal fluid will be filtrated, formed, in other words, inferiorly in your body, and it will flow, this is the normal flow, upward toward these recesses. In these recesses, the peritoneal fluid will be absorbed again back into the venous circulation. Okay? So peritoneal fluid is the filtration of the plasma fluid from blood capillaries, okay, to become interstitial fluid, then peritoneal fluid, passing through the peritoneal membrane. So it will be entering into the peritoneal cavity from below, it will flow up and go to be absorbed here, okay, in the subphrenic spaces, okay, to go back into the venous circulation. Now if the patient has an inflammation in peritoneum, and the peritoneal fluid, the ascitic fluid, okay, inflammatory exudate, starts to accumulate there, and you put the patient in supine position, the rate of absorption of this inflammatory fluid here up in the subphrenic spaces in supine position will be high. So the rate of absorption, returning back peritoneal fluid, is much higher up. Okay? So that the inflammatory fluid will be absorbed back into the venous circulation, forming a complete generalized infection of the whole body. So you want to avoid this. So actually, if the patient has ascitic fluid, peritonitis, and you place him in supine position, you are actually moving this inflammatory fluid up to the subphrenic spaces where it will be absorbed and go to the whole body. So you produce what? A general inflammation of the whole body, which is a dangerous situation. So in these cases, we don't put the patient in supine position. Instead, you will see that the patient is placed with his back at 45 degrees angulated up, okay? So remember, when you have a case of inflammation of peritoneum, the patient is always in which we call it prone position, or his back must be leaned just 45 degrees, not more, okay? By this, the whole fluid will still accumulating instead of passing to the subphrenic spaces in the pelvic cavity. And we know in the pelvic cavity there is no absorption of peritoneal fluid because there is introduction of peritoneal fluid, okay? Secretion or formation of the peritoneal fluid. So the filtration there of peritoneal fluid happened below. So by this we will reduce the absorption of this inflammatory fluid back into the venous circulation. Okay? So that's the reason when you have an ascitic fluid or peritoneal inflammation or infection, you avoid putting the patient in supine. Okay? Something else. Do you remember I told you that the liver is covered by peritoneum by 4 recesses. Okay, so the peritoneum covering 4 recesses: anterior to the right, anterior to the left, posterior to the left, posterior to the right. As these 4 parts of peritoneum form, for example, let's take the first 2 here. Okay, if I do this, this is the liver, these are the 2. You will see that as they covering the peritoneum, the anterior to the right, anterior right subphrenic space, anterior left subphrenic space. Between them, there is double layer of visceral peritoneum reflecting. These 2 layers reflecting from the liver, anterior abdominal wall, and the diaphragm. As they reflect, and because of the convexity of the liver, they will form 2 visceral layers of peritoneum. If you see, this is the first recess, this is part of visceral of it, and it will go towards the abdominal wall. This is the other recess which will go towards the abdominal wall. So 2 recesses around anteriorly. As they reflect, you will have double layer of visceral peritoneum here, passing towards the anterior abdominal wall and the diaphragm superior. Okay? So this passing here will form what? A peritoneal reflection. Double layer of visceral peritoneum reflected from the liver towards the abdominal wall. What I will name this reflection from a solid organ? It is a ligament. So if you remember, we said when we have peritoneal reflection from solid organ to another organ or to abdominal wall, we will name it ligament. So this is a peritoneal reflection with 2 double layers passing anteriorly. So this now will be a ligament. Because of the shape of this ligament, up to the diaphragm and to the anterior abdominal wall, like sickle, مثل المنجل. So we will name it falciform ligament. Okay? So this is which we call the falciform ligament on the diaphragmatic surface of the liver. It happened because of reflection of the right and left anterior recesses back anteriorly to the anterior abdominal wall. So this reflection here, these 2 layers will be named the falciform ligament. So this is the falciform ligament. Superiorly now, again, the last thing about the diaphragmatic surface, you remember I told you peritoneum comes from below. Remember this. It will form anterior right recess, anterior left, posterior right, posterior left. And here we will have double layer. This is the falciform ligament attached to the anterior abdominal. What about this area here, which does not have peritoneum? So there is the superior area of the liver actually is empty of peritoneum, in direct contact with the diaphragm. So there is no peritoneum, if you see, because as the peritoneum comes from below, it doesn't cover the topmost area of the liver. By this area of the liver, I will name it bare area of the liver. Bare means naked. Okay, there is no peritoneal covering. So this here you will see a bare area and it's rough. If you look to a real liver, you will see that the peritoneal covering will always give a smooth glistening surface. Certainly at a certain point, at the superior part of the liver, you will see that the liver become very rough surface, okay, and lose its glistening appearance. Okay, so by this we call it the bare area of the liver. So how the bare area of the liver formed? Because the recesses start to separate away from each other, forming this bare area of the liver. Okay. So at the diaphragmatic surface, we have bare area devoid of peritoneum. If you look carefully, we have falciform ligament and we have 4 subphrenic recesses. Okay? The 2 layers of falciform ligament, as you see, as it goes up, they start to separate, of course, because the peritoneum don't reach. So this split between them will form the bare area, which will extend also on the superior surface of the liver. The visceral surface now. So on the diaphragmatic surface, we have falciform ligament reflection. We have 4 recesses. These recesses, once they reflect anteriorly, they form falciform ligament. Superiorly, there is no peritoneal covering, and we name it bare area of the liver. On the visceral surface, if you look, as I told you, it's visceral because of its relation to viscera. You will see so many depressions. Okay? These depressions, we name them according to the organ forming them. Okay? So if a depression, we call it impression usually. Okay? If this depression or impression happened on the left side by a large organ, this will be named on the left side, sorry. On the left side. The liver, what's there? The stomach impressing on the liver. So this will be named the gastric impression. On the right side, most posteriorly, the kidney, the right kidney. Okay? So we will have the renal impression. Anterior, there is the ascending colon. As it's going up, it will hit into the visceral surface of the liver. So it will fold towards the left side to become transverse colon. So this is called the right colic flexure. The right colic flexure actually happened because of the presence of the liver there. So anterior on the right side, you will find the colic impression by the colon, okay, where the right colic flexure is located. So we have on the left, on the visceral surface, we have several impressions. To the left, you can see the gastric. On the right, posteriorly, you can see the renal. Anteriorly, on the right, you can see the colic impression, okay? And you can see also another small depression here. This is, we usually call it a little bit posterior. So this is your homework. Find what is the fourth organ forming impression, okay, on the visceral surface of the liver. So there is a fourth one. The visceral surface of the liver is also covered with peritoneum, except two areas. Except in two areas. Okay, the first area is where the gallbladder is resting, because the gallbladder is in close proximity to the liver. Okay, if this is the surface, the visceral surface of the liver, and this is the gallbladder, it's in close contact with the liver. So if the peritoneum comes to cover, it will cover the visceral surface, reflects above and covering even the gallbladder and go. Okay? So instead of passing first between the gallbladder and the liver, it doesn't do this because of the close proximity, it passes from above the gallbladder. So in this area here, between gallbladder and the liver, there is no peritoneum. Okay? Just like this, the peritoneum has. By this, if I cut the gallbladder and remove it, I will find where it's resting a rough surface of the liver. So this is what we call it the bed for gallbladder. The bed means the area where the gallbladder is resting. So the bed for gallbladder does not contain peritoneum. Okay? So if you remove the gallbladder and take a look to the surface of the liver, you'll see it's going smoothly. At a certain area, it will become in this region very rough. Okay? Where the gallbladder is resting. So this is the first area. The second area, which makes sense, is the gate of the liver. Any organ must have a gate. Okay, what we mean by a gate? A door. Okay, to allow for vital structures to pass, for arteries and nerves to get in, for veins to leave. So in this case, if the liver was completely covered by peritoneum, the blood vessels required for the liver cannot pass. So I need an area which is open, okay, to allow for the root of the liver to pass. The root of the liver indicates the structures, enter and leave. Like the lung, it has a hilum and has a root. The root of the lung شو أخذته بالرespiratory system? Pulmonary artery, pulmonary vein, bronchus. Okay? Three structures. Once they enter, the area where they enter in the lung, we call it the hilum of the lung. The same here. We have three structures. Portal triad. So portal triad, the portal vein, hepatic artery, هذول الاثنين بيدخلوا واللي بيطلع bile duct, okay, which secretes the bile. Those three, the portal triad, are actually the root of the liver, okay, and they enter and leave through the hilum of the liver. The hilum of the liver has a different name here. You can call it still hilum of the liver, but it has a specific name. We call it the porta hepatis in Latin. Porta means gate, hepatis means liver. Okay, the gate of the liver. So porta hepatis. So on the visceral surface, in the middle, in the center of the visceral surface of the liver, you will see an opening there. This is the porta hepatis. And you will see three structures getting in or leave through the porta hepatis. Okay, these will be portal vein, hepatic artery, and bile duct. So this area must not contain peritoneal covering. So it's devoid of peritoneum. So two areas without peritoneum in the visceral surface of the liver. Those will be the bed where the gallbladder is resting and the porta hepatis or hilum of the liver. By this, I have three areas devoid of peritoneum on the liver. One on the diaphragmatic surface superiorly, bare area, and two on the visceral surface, gallbladder bed and porta hepatis. Now, this is for the surface anatomy of the liver. What about the internal or the complete structure? Like if we divide the liver is usually divided anatomically, structurally into four parts. Lobes. Lobe means part. So four parts. Physiologically, functionally, and وظيفيا, it's divided actually into two parts. Okay? So we have four parts and two parts. The four lobes of the liver, the largest one, if you look carefully, is the right one here. We name it the right lobe of the liver. They are separated by the falciform ligament. If you look to the falciform ligament, on the right side we have the right lobe of the liver, on the left we have left lobe of the liver. Now if you look to the visceral surface, this is the right, this is the left, but actually you will see one here stuck between the gallbladder and this ligament on the visceral surface. We will talk about it. This is more or less quadrangular in shape, murabba. So we call it the quadrate lobe of the liver. And the one behind, which is between the inferior vena cava and another ligament here, it's like a tail if you look to it. So we name it the caudate lobe of the liver. Caudate means the tail. So structurally, by looking, we can divide the liver into right, left, quadrate anteriorly, and the tail posteriorly, the caudate. Okay? Quadrate and caudate. However, if you look functionally, you see that hepatic artery actually has two branches, right, left and right. The portal vein نفس الشيء, له left to right branches, only two, not four. So functionally, the liver is divided into two lobes, not four lobes. Because actually, blood filtration and oxygenation in the hepatic artery, filtration in the portal vein, with secretion of bile, that caudate to the quadrate, they pass along with left lobe of the liver. So functionally, the liver is two parts, right and left one. Okay? So when we speak about the function, blood filtration, okay, or production of bile, quadrate and caudate lobe are considered, or they produce their function along with the left lobe of the liver. Okay? So physiologically, it is two lobes, but anatomically, by looking, descriptive four: caudate, quadrate, left, and the largest one is the right lobe of the liver. Okay? Now the important thing, ligaments of the liver. When we speak about the ligaments of the liver, you have to remember we have two things here. We have ligaments that are actually peritoneal reflection, so not true ligaments. And those are located on the diaphragmatic surface of the liver. Okay? Superior, anterior. By the reflection of the recesses we spoke about. However, on the visceral surface you can find two real ligaments, fibrous ones, okay? And we will speak about them. The reflections now, the most anterior ligament, we talked about this one, which is sickle shape, okay? This is, we name it the falciform ligament because it's shaped like a sickle. It's located anteriorly. And here it attaches always in anatomy, does not exactly mean there is a true attachment. It just reflects from the anterior surface of the liver towards anterior abdominal wall. After these two double layers of peritoneum reach the abdominal wall, they will become parietal peritoneum and separate again like this, okay? Right and left. So it attaches the liver to the anterior abdominal wall. This is called the falciform ligament. Between these two layers, as they separate, so remember, I told you, this is here the liver, it has this appearance, and we have these two recesses. This layer and this layer of two recesses, those two layers are the falciform ligament. So between them now, inferiorly, there is a true ligament, passing from the inferior surface of the liver to the anterior abdominal wall, to the umbilicus. Okay? This is another ligament, we name it ligamentum teres, and this is a true ligament. Ligamentum teres. Teres means cylindrical, okay? So it's the cylindrical ligament or round ligament. That's why its other name in English, round ligament of the liver, okay? So ligamentum teres or round ligament of the liver. So if you look, the double layer of peritoneum here, which forming the falciform ligament, as they reflect between them, there is a true ligament passing inferiorly, okay? From the liver, anteriorly going where? To the umbilicus. This is named ligamentum teres. And it is actually located on the visceral surface of the liver, so we will cover it when we reach the visceral surface. Now the double layer of falciform ligament also, superiorly they separate, as you saw here, okay? As they separate, they are widened up, one to the right, the other one to the left. So if you look to the superior surface of the liver here, this is falciform ligament, so the right part will be separated to the right, the left one will go to the left. The same for the posterior recesses. The right posterior recess here, which we name it hepatorenal. As it comes, the upper part of it will be split. This is one, and the other recess here will have its peritoneal sharing. Now if you look carefully here on the superior surface, so now you will have 4 layers of visceral peritoneum. Anterior right layer, anterior left layer, posterior left layer, and posterior right layer of peritoneum. Because the peritoneum here starts to separate away from the topmost, forming the bare area of the liver. The anterior right layer of peritoneum, which will reflect on the diaphragm, and the posterior one, which will reflect on the diaphragm but posteriorly this time. Those two far away layers from each other, as they are 2 layers, I need 2 layers of visceral peritoneum to have a ligament. And look carefully, they're going far away from each other because of the presence of bare area here. Okay? These two, they form like a crown over the head of the liver. عملات زي التاج. So I will name them coronary ligament of the liver. Okay? So those are named coronary ligament of the liver. Okay? Like a crown. So we have the coronary ligament of the liver here on the right side. Right side of the liver or right lobe of the liver is very wide, as you know, while the left one is very narrow. So the 2 layers on the left now, not like this. If you look to the 2 layers, because of the narrowing in the left lobe of the liver, they don't get separated from each other far away. Instead of forming the shape of a crown, they form the shape of a triangle. So we don't call them coronary ligament, we name them left triangular ligament. Okay? So these will become the triangular ligament of the liver, and they will be reflected into the diaphragm. The 2 layers of coronary ligament, as they become to the right angle of the liver here, they will also become close to each other in a triangular form. So they will become the right triangular ligament of the liver. So all these peritoneal reflections or ligaments on the superior surface of the liver, on the right side you have coronary ligament, so we have 1 coronary ligament, okay, on the liver on the right side. This is because of the widening, okay, of the right lobe of the liver. So the 2 layers separated become like a crown. The coronary ligament will become at the right corner, more close to each other, so it will become the right triangular ligament. However, on the left lobe, we have 2 close layers of peritoneum that form the shape of a triangle. So we call it left triangular ligament. Both right and left triangular ligaments are reflecting, or we say attaching, the liver to the diaphragm. Okay? So how many peritoneal reflection I have now? Anteriorly I have the falciform ligament. Superiorly on the right I have coronary ligament and right triangular ligament. While on the left I have the left triangular ligament. Okay? So I have 4 ligaments on the diaphragmatic surface. Those are peritoneal ligaments. In other words, reflections of visceral peritoneum. Okay? Now on the visceral surface, if you look carefully, you will see true fibrous ligaments. The anterior one here, which separates the left lobe from the quadrant. So this one will go, as you see, it's attaching to the left branch of portal vein. This fibrous tissue passing from the portal vein in a groove here in the liver all the way anteriorly to reach the umbilicus of the anterior abdominal wall. As it passes, it will be moving between the two layers of the falciform ligament. If you look here, these are the two layers of falciform ligament. You see here a fibrous ligament come from anterior and pass, as you see it here, towards the umbilicus. This is called the round ligament of the liver or ligamentum teres. This is an embryological remnant. It is the obliterated اللي بيسكر بعد ما تنولد ايش؟ umbilical vein. This is the obliterated umbilical vein, and it is important in determining the quadrate loop. If you look, the quadrate loop of the liver is wedged between the gallbladder to the right and the ligamentum teres to the left. So it's a remnant of what? Of the umbilical vein. You remember that you have something in the fetus named umbilical cord, الحبل السري اللي لما ينولد على طول بقصوه. Okay. الحبل السري هذا umbilical cord contains four main structures. Four structures. The largest of these tubes is the umbilical vein, okay, which takes blood from placenta and get it into the fetus. Remember, the circulation in the fetus from placenta to the fetus is inverted, مثل pulmonary circulation, because what's coming is a vein, okay, and what's leaving from the fetus is the artery. So you have a large umbilical vein, الحبل في umbilical cord, and two small umbilical arteries. Umbilical arteries return ايش؟ اللي هو unoxygenated blood from the fetus towards the placenta. The umbilical vein brings nutrients and oxygen from the placenta towards the fetus. Okay? So the most important of these four structures, umbilical vein, two umbilical arteries, وفي كمان duct. دوروا عليها. Okay? It's very important. The four tubes within the umbilical cord. The largest of them is the umbilical vein. This is to show you the story. From placenta, شوفوا الumbilical vein is reddish because it's oxygenated. بيدخل عبر الامبليكس. الآن بعد ما يدخل, it will pass to the liver. At this stage, during fetal development, the liver is not functional developed. Okay, not functionally developed. So there is no need for blood to pass into the liver. Instead, the blood will shunt. يعني بيعمل تحويل. Instead of passing into the liver, it will shunt from the liver backward to the inferior vena cava. So it will go to the heart directly. Because the liver is not functionally developed yet. Okay? By this, as it will shunt, okay, instead of going to the portal vein inside the liver, then leave through inferior vena cava, it will shunt towards. By this shunting, so الدم بيكون يجي بالفيتس عبر هذا الامبليكال فين. اوكي؟ بيوصل البورتال فين. الان الليفر مش فانكشنال، بدل ما يدخل على الليفر بيعمل شنط عبر انذر فين. شايفينه هذا الفين الصغير هون بيكون وبيروح للانفيرير فينا كيفا. ومن الانفيرير فينا كيفا it will go up into the heart. So this actually in the fetus another vein. We call it ductus venosus, the venous duct. The ductus venosus or the venous duct is a shunt for blood from portal vein to the inferior vena cava to bypass the liver, مشان يتجاوز الليفر. So the blood in the fetus passes through umbilical vein, then from the portal vein through ductus venosus into IVC, then to the heart. After birth, when the liver becomes very functional, these two structures, بتقصوا umbilical cord, the umbilical vein and the venous duct here, okay, they will be obliterated by fibrous tissue. You see fibrous accumulation of collagen fibers accumulated, and they close the whole lumen. So the umbilical vein become ligament. Okay, we call it ligamentum teres or round ligament of the liver. The ductus venosus or the venous duct will also be obliterated. So it will not become a duct anymore. It will become a ligament. So instead of ductus venosus, it will become ligamentum venosum. Okay, or venous ligament instead of venous duct. So this is the story of those two true ligaments in the liver. They are actually embryological remnants. The first one from umbilicus to the portal vein, left branch of portal vein. This is, we name it ligamentum teres, and it's remnant of umbilical vein. Okay, and the other one here from portal vein to IVC. This is called ligamentum venosum, and it is the remnant of the ductus venosus, which is the shunt, the wheel between portal vein and IVC. Okay? In some cases now, in surgical procedures in adults, لما بيسكر ايش؟ البورتال فين. ليش؟ بصير عنده بعض البيشنتس ايش بسموه؟ ليفر سيروسيس. You know what's liver cirrhosis? بتشمع الكبد. Okay? So as the collagen fibers inside the sinusoids of the liver close, بصير liver cirrhosis. So blood in normal situation cannot move into through portal vein into the liver. So there will be accumulation of the blood in the portal vein, portal hypertension بيرتفع بصير عنده. So to avoid this, what they do, the surgeons, they produce a shunt. So you surgeon get in and open the portal vein and attach it with a tube passing over this region into the inferior vena cava. So they will produce a shunt. This is which we call it portocaval shunt. Surgical treatment for portal hypertension when the patient has a liver cirrhosis problem. So actually what they do, they produce a synthetic ductus venosus in adults. This is called portocaval shunt. Quick review of the liver. The liver has two surfaces. شو هم؟ Diaphragmatic و visceral. ليش سميناه diaphragmatic؟ Facing the diaphragm. ليش سميناه visceral؟ Close proximity to four structures mainly. Kidney, stomach بالليفت, right colic flexure وفي another organ مطلوب منكم. The liver is four lobes anatomically اتذكروا اللي هم ايش؟ الرايت لوب، الليفت لوب، الفيسرال سيرفيس كوادريت anteriorly بين الليجامنتم تيريس والجول بلادر. التيل posteriorly بين الاي بي سي ligamentum venosum, the remnant of the venous duct. Okay? So four lobes, caudate, the tail, quadrate, left lobe, right lobe. Functionally speaking, in physiology, it's two lobes, left and right. Okay? Ligaments, there are 6 ligaments on the liver. These 6 ligaments, 4 of them are peritoneal reflections, okay, false ligaments, and 2 are true fibrous ligaments. These 6 ligaments, one is located anteriorly. This is it. شو سميناه؟ Calciform, المنجل. Superiorly we have 3. اللي 2 separated في الرايت سايد عملات مثل التاج. Coronary. As the 2 layers of the coronary approximate each other at the right corner, they will become right triangular ligament. On the left we have left triangular. كم صاروا؟ 4 peritoneal reflections, 1 anterior, 3 superior. Inferiorly we have another 2 ligaments. What are these 2? Ligamentum teres, which is a remnant of umbilical vein in the fetus. And the other one is ligamentum venosum, which is the remnant of ductus venosus, the shunt in the fetus. The porta hepatis in the middle, if you look carefully now, this is the opening of the liver. It's located between which lobes? Anteriorly, quadrate, posteriorly, caudate, the tail. To the left is the left, to the right is the right. So it is in the center. This is just to let you know that porta hepatis or hilum is located in the middle of the liver. Last thing, bile duct system. We'll continue next lecture. The bile duct system now. This is related to the important function of bile production. You know that the bile is produced and secreted by the liver. However, when there is no need for it, like at this time of the day, when you are not digesting, okay, it will be stored where? In the gallbladder, okay? As it's stored there, the water will be lost from it and become concentrated. So storage and concentration of bile. At the lunch time or at the dinner time now, all this bile will be secreted, okay? So then we need a specific system of ducts to drain this bile. To drain this bile, we have a specific system of duct. We call it the biliary system of ducts. We have 2 ducts secreting the bile from the liver. The one from the right lobe is the right hepatic duct because it's coming from the right lobe of the liver. The one that drains the bile from the left lobe, quadrate and caudate lobes, we will name it left hepatic. Okay? Left hepatic duct. So we have a right and a left hepatic duct. When they both join together here, they become common hepatic. Now the common hepatic will be joined with another duct coming from this cyst. What is cyst in medicine? Look for this. Try to find why we call it cystic duct. Because it comes from a cyst, which is the gallbladder. Gallbladder is a cyst. So we call it cystic duct. Now this cystic duct will join the common hepatic duct. So this duct no more coming from one organ, the liver. It comes from two organs. So now I will name it common bile duct. So the common bile duct is the duct that formed by the joining of common hepatic and cystic duct. The common bile duct will pass in the posterior abdominal wall behind the duodenum. So it's retroperitoneal now. The common bile duct descends behind the first part of duodenum. After that, it will move, as you see, from behind the duodenum, behind the head of the pancreas. So it will go behind the duodenum, behind the head of the pancreas, then it will penetrate the head of the pancreas there to join the main pancreatic duct. Okay? As it joins the main pancreatic duct now, you see here, it will become the ampulla of Fetal, okay? Or ampulla of Fetal, okay? Whatever name you like. So it will become the ampulla of Fetal, and the ampulla of Fetal will open in the second part of duodenum. So the relation is important here. Common bile duct descends behind the first part of duodenum and behind the head of the pancreas. Then it penetrates the head of the pancreas to join the main pancreatic duct in the ampulla. Gallbladder subdivided into three parts. There's a fundus, a body, and a neck. What's important in the gallbladder now is its arterial blood supply, because this is important during cholecystectomy. What is cholecystectomy? Surgical removal of the gallbladder. لما بتلتهب أو لما بصير فيها stones, okay, gallstones. So during cholecystectomy, before cutting or removing the gallbladder, you have to ligate the blood vessel supplying the gallbladder, which is named cystic artery. Cystic artery usually more than 70 to 75% of times is arising from the right hepatic artery. Remember this. So if you to find this artery, you have to follow the right branch of hepatic artery, because this artery is very small. It's very difficult to find this cystic artery. So the surgeon, what he will do instead, he will go and follow the common hepatic into right and left branches, then go with the right hepatic, then at the right hepatic you will find a very tiny small branch. This is the cystic artery, he will ligate it. In different times you will see that the cystic artery coming from the left branch or coming from the hepatic proper artery. Okay? It varies, but 75% of times it's from the right hepatic artery. Okay? Remember this, cystic artery from the right hepatic artery. Next lecture we will continue with the pancreas.